So now the question arises, should we switch all the patients who are taking ACE inhibitors and ARBs on heart failure? Should we switch them to ARNI? And when should be the switch done? Should we wait for the patient who is stable to become unstable? So the answer for this comes from the Paradigm Heart Failure trial. So in the Paradigm Heart Failure trial, a large number of patients, 20% of the patients experienced cardiac events. 17% of the deaths were in stable patients. In fact, 51% of the deaths occurred even before heart failure hospitalizations. So we can understand even the stable patients of heart failure are not stable. In fact, there is a myth to call the heart failure patient stable at all. There is no stable heart failure patient. The heart failure patient is continuously progressing towards his death, and drugs like ARNI can arrest this progress towards death. And therefore, it is prudent to start the heart failure medications like ARNI as early as possible after diagnosis, because early diagnosis can prevent the cardiac events in the future and also can lead a better prognosis. Now, should we switch all the patients with ACE inhibitors and ARBs to the ARNI? For this, we go to the Paradigm Heart Failure trial again. We have a overwhelming evidence that as compared to enalapril, the ARNI, sacubitril valsartan, has a tremendous benefit in reducing the cardiovascular deaths, heart failure hospitalizations, improving the quality of life. It adds to the life of the patient, 2 years to the life of the patient if you switch from the enalapril to the ARNI. The cardiac deaths are reduced by 20%, heart failure hospitalizations are reduced by 20%, and therefore it is prudent that you switch over from the ACE inhibitors and ARBs to the ARNI. Even the latest guidelines also suggest the same thing, that you should prefer ARNI as a first line therapy for heart failure management, and if your patient is already on ACE inhibitor and ARB, he should be shifted to the ARNI. ACE inhibitors can be given to the patients of heart failure only if for some reason, maybe financial, you cannot give the ARNI. For those reasons, you may shift from the ACE inhibitor to the ARNI. And as far as ARB are concerned, they come even lower. The ARB can be taken only if ACE inhibitors are not tolerated. So I think it is very important that you shift your patients from ACE inhibitors and ARBs to the ARNI, and that shift should occur early, because we know that even if your patient is stable, he is continuously progressing towards his death, and even if the patient is discharged in a stable condition from the hospital, there is a high chance of him coming back to the hospital in next few months, and therefore ARNI can prevent that, and therefore it should be initiated as early as possible in the stable patient as well as in the discharged patient who is apparently stable.